Vaccine-preventable diseases, VPD, still kill many children 5 years and below in Uganda and more than 500,000 children in Africa every year. According to the Ministry of Health's Uganda Demographic Health Survey, UDHS 2016, only 79% of the children eligible for the diphtheria, tetanus and pertussis vaccine received it, which is below the Global Vaccination Action Plan target of at least 90%. From 2014, the John Snow Research and Training Institute has implemented a 5-year project dubbed Stronger Systems for Routine Immunization, SS4RI. This project's main goal has been to strengthen the routine immunization system at the subnational level that's across 10 districts with the lowest immunization coverage, and at the national level where it has provided technical support to the Ministry of Health's Uganda Expanded Program on Immunization.
Its approach of implementation has been reaching every child, which is a well-known strategy for immunization improvement by WHO, but adding quality improvement approaches and tools to improve the implementation of REC or RED in Uganda.
As Kalungu district, we had been performing very poorly in immunization. And on taking a keen interest on some of the underlying causes as to why the performance was not good, we realized that there was a missing component in leadership and management of routine services of immunization. So with the support from SS4RI, the district brought together in charges from the different facilities in order to orient them about leadership and management plus accountability.
During SS4RI implementation of this intervention, a number of observations and learning has emerged. The project spoke to 4 health managers from 4 implementation districts who shared their positive experiences and emerging themes of improvement in their support to retain immunization service delivery.
It was not easy before. We didn't know what to do and where to start from. Looking at the district target population, our population is about 28,000 something, which is the biggest. And also this sub-county having only one health facility, it was not easy for us to cover all that wide population. In general, we also got knowledge on routine immunization like microplan, which was completely not there and people didn't know about making of microplans.
As a leader, I used to do things my own way, like planning for outreaches. I would just sit down and decide on myself that we have to put an outreach on a certain trading center, but after the SS4RI intervention, we had to sit down as a group, as a team, and decide on what to do.
It was not guided by any microplan, and we could not mind of how many children, even if we go and find 1 or 2, it was not an issue. The issue of numbers and target was not an issue. We could just go for the sake because we expect at the end we have done it and we have reached the community. But after looking at our outreaches and increasing the numbers up to about 8 sessions in a month, we realized we were able to reach out to those children in different areas within our catchment population.
We realized that if we have to reach every targeted child and population, we need good leaders. Leaders at health facility level, leaders at district level.
We received the Gavi motorcycle from the district and I think Ministry of Health. We had also our small, it is a mate type Yamaha small motorcycle, this unit. But we are using those motorcycles for solely art services, HIV services and other services. So for EPI we would get money, pay border person to go for an outreach. Yet we had 2 motorcycles at the unit. So after that training of leadership management and accountability, they told us those motorcycles were solely for, in fact this Gavi motorcycle, solely for EPI services.
Another gap also that existed before was about financial management and budgeting. After the training, we were oriented and were given clearly our roles, which opened our eyes, and we started now budgeting carefully, and we had to allocate more budgets for routine immunization. And as a facility, at the moment we are giving 42% of our PHC for routine immunization, which I feel it is good, and we are now able to pay all the routine immunization activities that are conducted within a quarter.
Before SS4RI, people thought and knew budgeting and issues of finance was strictly for in-charge. People would go by what in-charge decides and what is there. And for now, there's a finance committee. Money is being allocated and delegated to each department where they make requisitions, and the account, then the in-charge will make the final accountability and submit.
We used to do immunization alone as health workers. But when SS4RI came in, we had to bring in even more stakeholders.
We involve other non-health stakeholders like the sub-county chief, the chairperson management, and other relevant community stakeholders who come to give us support in planning and allocating resources to other departments.
Based on the good relationship between non-health stakeholders, we have managed to lobby and get a lot of support from sub-county and also from like parish chief in terms of transport, allocating an extra motorbike for going to outreaches, also buying of megaphones, and also allocating funds.
At the moment, the sub-county is supporting us with the 200,000 per quarter to support routine immunization. They also procured for us a new bus call who is able now to take us for outreaches.
The leadership management and accountability training enabled health facility managers to work with their teams in identifying existing gaps in routine immunization, and they came up with innovations to resolve these. Many of these innovations were benchmarked on locally available resources and did not require additional budgets like most.
After SS4RI's intervention, we had to find ways of how to improve. And one thing we did is the quarterly immunization days. During these quarterly immunization days, we call almost every child below 5 years. They come here at the facility with their mothers or caretakers, and a lot of activities go on. So quarterly immunization days work as a mop for the health facility. Even those ones that you would have missed in the past 3 months, you see them coming.
At the moment, we're able to display the PHC funding, how it is being utilized, how it is being accounted for. There's a lot of transparency. All the health workers are contented with how these PHC funds are being used. All the health workers are now being engaged in routine immunization because they feel whatever they worked for are being paid.
I can say when I'm talking to another in charge who has never received this training in leadership management and accountability, he has to delegate the PHC funds to the EPI focal person. It will review of the pressures and what. On top of that, it will bring yield. That EPI focal person will also be in charge of something and will feel the responsibility, like to make sure the project or process continues.
It has improved our performance. At the moment, we are in category 1. Our deputy 1 coverage is at 90.3%, and the dropout rate is at 3%.
Within the first quarter of the last financial year, that was July to September, that was when we came from category 4 to category 1, and we managed to sustain up to now our category 1. That means we have more children coming, and also majority of them, almost all of them, are also completing.
I would want to believe and encourage the empowerment of the managers at operational level. That is the health facility in charge, the medical superintendent of hospital, the EPI focal person, to empower them, to give them the skills, the knowledge and competencies to know the important things to be done as a manager. It is very, very important to involve the leaders of the communities we are serving. That is what we call non-health stakeholder engagement.
With all the skills gained, I have much hope for program continuity.